You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 29th, 2021. This week, stroke of unknown source, coronary artery calcium, Takotsubo syndrome, and chest pain. First, a brief note on COVID. In the United States, cases, hospitalizations, and deaths continue to decline, thank goodness. The first topic is anticoagulation in post-stroke patients with left ventricular dysfunction. Now, how best to treat a patient with a stroke of unknown source comes up often, especially for us EP docs who are often asked to place implantable loop recorders to monitor for AFib after stroke. The journal JAMA Neurology has published an interesting post-hoc analysis of the Navigate ESUS trial of rivaroxaban versus aspirin in patients who have had an embolic stroke of unknown source. Now, the question for this specific analysis was whether left ventricular systolic dysfunction modified the effect of rivaroxaban versus aspirin. In other words, was there heterogeneity of treatment effect? It's a good question because impaired systolic function can increase the risk of thrombus and then thrombotic complications. Now, recall that New England Journal of Medicine published the original Navigate ESUS trial in 2018. It randomized approximately 7,200 patients with stroke of unknown source to rivaroxaban 15 versus aspirin 100, and the trial found no difference in recurrent stroke or systemic embolism. Major bleeding was nearly 3 times more likely in the rivaroxaban group. Now, it's not only rivaroxaban that failed in embolic stroke of unknown source. Dabigatran also failed to significantly reduce stroke in the RESPECT ESUS trial of standard dose dabigatran versus aspirin in patients with ESUS. Though in this trial, dabigatran reduced strokes by 15%, but the p-value came in at 0.10, so did not meet that threshold. Now, these results have always seemed weird to me. I've always thought if you have an embolic stroke and you don't have atherosclerosis, it stands to reason oral anticoagulations would be better. And I wonder, is it patient selection? And that's why I was drawn to this JAMA Neurology paper that used patients in Navigate ESUS who had abnormal left ventricular systolic function. Now, 7% of the total of the 7,200 patients, or about 500 patients, had abnormal LV function on their baseline echocardiograms. Among these 500 patients, a recurrent stroke or systemic embolism occurred in 2.4% of those in the rivaroxaban group versus 6.5% in those assigned to aspirin. And among the 6,600 patients in the trial had normal LV systolic function, the rates were similar, 5.3% rivaroxaban, 4.5% aspirin. Those with left ventricular dysfunction assigned to rivaroxaban versus aspirin had a 64% lower risk of stroke, hazard ratio 0.36, and the confidence intervals showed that this was clearly significant. Those without LV dysfunction showed no such reduction. The hazard ratio there was 1.16. And the test for interaction between these two was significant at 0.03. So my comments. Does this mean we should treat embolic stroke of unknown source patients with impaired systolic function with oral anticoagulation versus aspirin? And the answer is no, it does not. And the authors are clear on this point, both in the manuscript and in the news coverage. Studies like this are essentially observational comparisons, and if you do enough post hoc comparisons, some will be significant based solely on chance. And really, a chance finding here is entirely possible because the delta, the difference, was based on only 22 strokes, 6 in the rivaroxaban group and 16 in the aspirin group. But this is a biologically plausible association. We've all seen embolic complications in patients with impaired LVs. If you go to the paper, you will find a very nice comment from the esteemed neurologist David Spence. Spence made the point that this is now the second subgroup analysis of Navigate ESUS to show lower rates of stroke with rivaroxaban over aspirin. The first was a subgroup analysis looking at ESUS patients who had PFO. Spence points out that the likely reason ESUS trials failed to show superiority of oral anticoagulation over aspirin is misclassification of large artery atherosclerosis, for example, carotid disease. Now, obviously, if you include patients with carotid disease, you're going to favor the trial towards aspirin. In the ESUS trial, Spence writes, large artery disease is defined by the presence of stenosis. But due to compensatory enlargement, many patients with high plaque burden do not have high-grade stenosis. So I wonder, if we better classified carotid disease in ESUS patients, and we excluded patients with carotid plaque burden, and or included those with LV dysfunction, we might be able to show anticoagulation is superior to aspirin. So the specific message here is that maybe there are groups of ESUS patients in whom oral anticoagulation may be of benefit. But the general message of this story is that non-significant trials can still teach us a lot. Trials with non-significant primary endpoints like Navigate ESUS shouldn't tempt us to think binary. For example, this doesn't work or this does work. The point of post hoc subgroup analysis is not to mistakenly make causal claims, but to inform future trials, such as a trial of ESUS patients with left ventricular systolic function and limited carotid plaque burden. Of course, friends, the medical conservative approach is that the onus of proof is on proponents of a therapy to show that it works in trials in some group of patients. Next topic is coronary calcium, which was back in the news this week. Before I discuss CAC, I want to make a disclosure. I am on record as being a skeptic that CAC has any role, period. Andrew Foy and I published our argument in the American Family Physician Journal, and I will link to it in the notes. We expressed many concerns, but one that stuck out is the Cac Zero Argument. Now, this holds that Cac Zero confers such a low future risk of events that it can allow stopping statin therapy. Now, the problem with that logic is that statins have been shown in oodles of RCTs to lower future cardiac events by about 25%. And Cac Zero has been studied only in observational studies. So, by saying that you can use Cac Zero to stop statins, you are using observational studies to refute RCT level data. Now, JAMA Cardiology published a cohort study of 24,000 patients with known obstructive coronary disease to determine the diagnostic value of a CAC score of 0 to rule out obstructive CAD. First author, Mortensen from Aarhus, Denmark. The authors used a Danish registry and included patients who underwent CTA because of symptoms. Median follow-up was about 4 years. This paper had 4 main findings. First, the authors first tell us the prevalence of obstructive disease in those with a Cac Zero. And it was about 6%, 725 of 12,000 patients, ranging from 3% in those younger than age 40 to 8% in those over 70. The authors then tell us the prevalence of Cac Zero in patients with obstructive disease. And here it was about 14% overall, 725 patients of 5,000. Now, crucially, this varied by age. When stratified by age, younger adults with obstructive disease were far less likely than older adults to have any CAC. For instance, 58% of patients less than 40 with obstructive disease had a 0 CAC score, compared with only 5% of patients who were 70 years or older who had obstructive disease. Now, this shouldn't be surprising, right? Because plaques are less likely to be calcified in younger people. Third point, the authors then tell us the diagnostic value of a CAC of 0 for ruling out obstructive disease. Now, they adjusted for other clinical variables, and they present this thing called a DLR, Diagnostic Likelihood Ratio. Higher values close to 1 mean the Cac Zero modifies the likelihood less, while lower values modify the risk more. Again, age mattered a lot. In those less than 40 years old, the diagnostic likelihood ratio of Cac was 0.68, or just 32% less likely to have obstructive disease. In those older than 70, the diagnostic likelihood ratio of a Cac Zero was 0.18, meaning these patients were 82% less likely to have obstructive disease. Figure 2 in their paper presented an example of a non-smoker male without diabetes and atypical chest pain with and without Cac. And it really shows a difference in absolute numbers. In those less than 40, the risk of obstructive disease using clinical variables was 6%. And then if you added a Cac score 0 plus the clinical risk factors, the risk now is 4%, the delta of only 2%. But for that same non-smoking, non-diabetic male with atypical pain older than 70, the risk of obstructive disease using clinical variables was 40%, but a Cac drove it down to 8%, a 32% absolute risk reduction. Now, the final data point the authors provided was the rate of MIs and death based on a Cac Zero. Among those with Cac Zero and obstructive disease, the rate of MI or death was 7 per 1,000 patient years compared with 4 per 1,000 patient years in those with Cac Zero and no obstructive disease. So the hazard for obstructive versus non-obstructive in Cac Zero patients was 1.5, which is not surprising because obstructive disease, we know, raises MI and death risk. What was novel, though, was that the hazard ratio for obstructive versus non-obstructive disease in Cac Zero also turned on age. In those with Cac Zero, younger patients had an 80% higher risk of MI or death if they had obstructive disease, while older patients only had a non-significant 24% higher risk. These 4 findings led the authors to conclude 2 major things. First, the diagnostic value of a Cac score of 0 to rule out obstructive coronary disease beyond clinical variables depended on age. The added diagnostic value of Cac Zero was smaller for younger patients. Second, in symptomatic patients who were younger than 60, a sizable proportion of obstructive CAD occurred among those without Cac and was associated with an increased risk of myocardial infarction and all-cause death. The accompanying editorialist wrote, quote, "The article by Mortensen et al. Should give pause to efforts to broaden the use of Cac score of 0 to de-escalate or defer statin therapy in all individuals." I totally agree, and here is why. We know that atherosclerosis begins early and worsens over years. Calcification of arteries takes time to develop. If you measure a Cac of 0 in a 40-year-old and use it to stop statins, you stand a not small chance of missing obstructive disease and taking away an intervention that reduces events. Now, if you find Cac of 0 in an older person who has had time to develop calcium, okay, you are less likely to miss obstructive disease. This study supports the argument that Foy and I made about de-escalating statins based on observational studies, especially in younger people. For instance, we know that the length of time exposed to lower LDL reduces the risk of events. That means the benefit of statins accrues over time. The young surely have more to gain from preventive therapies than the old. Remember, preventive therapies are in fact designed to create old people. As the editorialists write, this analysis serves as a reminder to physicians that the absence of calcium is not equivalent to the absence of atherosclerosis, particularly in younger adults and women. Finally, my friends, remember, there would be no temptation to remove beneficial therapies if there were no Cac scores. I remain a massive skeptic of this radiologic test. Next topic is Takotsubo syndrome. The Journal of the American Heart Association published a research letter on the sex and age-based trends in Takotsubo cardiomyopathy. The first author is Verin Padasapu, and I apologize if I mispronounced that. Takotsubo, aka broken heart syndrome or stress-induced cardiomyopathy, is an intriguing condition that mimics a STEMI, Patients can be very ill and then improve over days to weeks. We see this condition often. Now, the researchers used the National Inpatient Sample Database to report on trends from 2006 to 2017, and they basically found that the incidence of Takotsubo cardiomyopathy has increased steadily in both sexes, with women comprising 88% of cases, especially women greater than 55 years. The most prominent at-risk group is women aged greater than 50 to 74. Now, the authors speculate on why there is such an increase in women, but it's pure speculation. While we know sympathetic stimulation is related, every human being has periods of sympathetic stimulation, and most don't get this syndrome. I mention this paper for a couple of reasons. One, this is a good use of observational data, for example, telling us about trends over time. Second, I find everything about Takotsubo condition intensely curious. Why does it occur? Why in middle-aged women so predominantly? Why is it increasing? What are we missing in the environment that's causing this? If you have ideas, let me know in the comments. Final topic today is chest pain guidelines. Now, numerous authors have published an exhaustive guideline document for the evaluation and treatment of patients with chest pain. It's published in JACC and Circulation. The executive summary alone is 44 pages with 350 references. So first of all, congratulations to the authors, especially Chairperson Martha Gugliotti. Documents like these are a massive undertaking, and the text and reference will serve as an incredible reference and teaching tool, and such is a worthy endeavor, one that improves the greater good. Now, a couple of comments. Like all massive new guideline documents, the authors give us a top 10 take-home messages. And I understand why this is done, but I don't like it. It encourages folks to read the take-homes and not delve into the nuance. And along those same lines, the authors also put tons of stuff into these neat little colored boxes with strength of recommendations and level of evidence. And this too is standard practice amongst all guidelines, but I don't like it. Colored boxes belie the complexity of medicine. They simplify things that really cannot be easily simplified. Chest pain evaluation especially. I mean, the main ingredient for success in treating patients with chest pain is solid clinical skills along with extreme powers of listening and observation. A robot with the best AI and best guideline document there is would fail miserably at chest pain evaluation. It is a human endeavor. Now, most of the recommendations in this guideline come with low level of evidence and thus lend themselves to the narrative reviews. And the narrative reviews in this paper are excellent. I know many of you disagree with this concept, but I have long held that all guideline documents would be improved if they only had the narrative reviews and references, no colored boxes. If you disagree with me and you love the boxes, tell me why. A few specific comments about chest pain and points made in this document. The authors emphasize accompanying symptoms, and I think this is very important. While pain in the chest is common, it's crucial to pay attention to things like dyspnea, arm pain, and jaw pain. Always be alert when someone says they have jaw pain. And this too, always look at people. How do they look? People having unstable angina, MI, often look unwell. I love also the author's choice to make shared decision-making a number 3 point of emphasis. Now, a clear discussion of the uncertainties and possibility of adverse events and radiation exposure and cost and alternative options is a huge positive on its own. Shared decision-making is right care, not because it reduces overtesting, but because it increases the odds of aligning care with the patient's goals. For instance, some patients like the idea of more testing, others are fine with risk stratification or more minimizers. Shared decision-making should never be used as a cudgel to do less. The authors also put emphasis on pathways and structured assessment of risk. Now, I understand why they do that, but the thing with seeing chest pain patients are the tails of the curve, not the middle of the curve. No one wants to miss an MI or PE. Patients with low heart risk scores can have MIs, and patients with high heart risk scores can have non-cardiac chest pain. Structured assessment and risk scores are good for the middle of the curve patients, but these are the easy ones. I am not convinced that risk scores help that much. And finally, as for the matter of overtesting and overtreatment, which is a real problem in chest pain evaluation, I see only one antidote, one solution. Someone has to write in clear language how many missed PEs or MIs are allowed. For if it is 0, overtesting will continue. That's because in the real world, medicine is practiced in the tails of the distribution. So that's it for this week in cardiology. As always, I am very grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating, write us a brief review. This helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.